Hello, this is my clinical reasoning presentation over 13-year-old BH by myself, Roger Turpin-Allison. So as you can see here are subjective data. BH presented to our office with his mother with complaints of cyclic vomiting and a persistent headache over the past few days. He states that on Thursday his vomiting started, lasted for 3 days, but on day one his migraine began and has been persistent since. Now he's rating it a 4 to 5 out of 10, but on Thursday it was about a 5 to 6 out of 10. He denies any over-the-counter medications, such as Benadryl or NSAIDs. His abortive medication is Axer. He takes that 12.5 milligrams. Describes his headache as being all over, a throbbing sensation. He also takes Zofran 8 milligrams as needed and 8 milligrams of periactin for prevention. He does report a sensitivity to light with no specific triggers, but his mom thinks that it's more on a calendar base because she notices migraines about every 12 to 13 weeks. Subjective data here, as you can see, past medical history, current medications, immunizations, allergies, family history, there's none that's prevalent, and social history, none reported. He is restless, reports facial pain all over, reports fatigue, severe headache, light dizziness, and migraines without aura at baseline. Objective data here, his physical exam. The patient's blood pressure usually runs on the lower side, according to my preceptor. So we decided to actually hold the magnesium infusion, which you'll see later in our regimen that we decided to do. So our objective data, review his systems here. As I said, he was calm, cooperative, just restless. From what we could see, since he was very sensitive to light in regards to his eye exam, he did have perla. They were reactive to light accommodation and all the good stuff. Neuro, as I mentioned, light sensitivity, but he was alert to person, place, and situation. Skin checked out, respiratory wise and cardiovascular wise, he checked out. Clear auscultation, S1 and S2 heard. At the time, his bowel sounds were present and hypoactive. They weren't hyperactive, indicating like nausea or diarrhea or anything like that. And as we mentioned, he was calm and cooperative. So my differential diagnosis includes cyclic vomiting syndrome, induced migraine, abdominal migraine with vomiting, GERD, and ICP. Our pathos for all of my differentials, CVS and abdominal migraine with vomiting are very similar. So I'll just read one patho because they are literally identical. So the exact patho for both are not fully understood, but current evidence does support a brain-gut interaction disorder with a strong relationship with migraine biology, autonomic dysfunction, mitochondrial abnormalities, and HPA axis dysregulation. And as we know with GERD, that is when gastric contents reflux into the esophageal area, causing mucosal injury due to things such as lower esophageal sphincter dysfunction. And there are other causes listed there as well. In ICP, increased intracranial pressure refers to the pressure within the skull, which the normal range is 5 to 15, but things such as brain tumors, hypoxia, and obstructive hydrocephalus can all cause an increase in ICP. So our final diagnosis, as you can assume, since the patient has a history of it, is cyclic vomiting syndrome, induced migraine. Farm-wise, we decided to go with tier 1 IV headache and migraine regimen, which includes IV fluid bolus of normal saline, followed by 4 milligrams of Zofran infused, 25 milligrams of Benadryl, and 15 milligrams of Toradol also infused. Patient got sent home with the Toradol bridge, 10 milligrams to take 3 times a day for the next 3 days, and to continue his omeprazole for gut protection while on his Toradol bridge. We also started him on magnesium oxide and B2 for preventative measures, in addition to his periactin. Non-farm, we just influenced, increasing his fluids to 64 fluid ounces, eating regular meals, breakfast, lunch, and dinner, giving him updated migraine action plan and 504 plan for school, for specific accommodations, and the patient to follow with GI, in regards to his endoscopy that is to occur next Wednesday to rule out other GI conditions. And the patient was also ordered a Nerivio device for abortive measures as well, and this is very non-invasive. So patient education and referral, as well as monitoring follow-up, is kind of repetitive as our non-farm interventions. But the patient is already mentioning, as I mentioned, following with GI for an endoscopy. We want to monitor electrolytes during CVS episodes, specifically magnesium, sodium, and potassium. The patient is to follow up in 1 day. If symptoms return or have not subsided with the Toradol bridge for a second infusion. Following the infusion, the patient did rate his pain as 0 out of 10. So he had a 100% decrease in headache reduction, and the goal is for at least a 50% reduction. And as I mentioned, 64 fluid ounces daily, regular meals, his migraine action plan and 504 plan. And the patient's following with GI for that endoscopy. The Nerivio device was ordered, and we also educate the patient on to not be alarmed that his urine may present as a bright yellow color due to the B2, and that he may experience loose stools or even an upset stomach due to the magnesium. So here are my references. That was the end of my presentation, and thank you for listening.